Friends, we are going to talk about an important topic, X-ray reading. Many people consider X-ray is an extension of the clinical examination. Konrad Röntgen is the one who discovered the X-ray in 1895. Actually, he is called as father of diagnostic radiography. Can you see the first image? Actually, this is the image of his wife's hand with a wedding ring. X-ray is a part of electromagnetic radiation. You can say that at one end, X-rays and gamma rays, ionizing radiations. At the other end, when the wavelength is more, it becomes radio waves. You all know the several applications of electromagnetic radiation. The universal X-ray chest view is called as PA view because PA view is nothing but a posterior-anterior view. It is usually taken in adults. Here the adult faces the X-ray film and the X-ray beam passes from posterior to anterior, actually at a distance of around 2 meters. That is very important because if you take such a film, it is a very good film without any magnification. That is a distinct advantage of PA view. What we are taking in children is the AP view, that is anterior posterior view. Actually, children are not able to cooperate in a standing position. They usually lie down. So here the X-ray is placed behind the child, either in the lying or sitting posture, and the X-ray beam passes from anterior to posterior. Because of this, it has some disadvantages. Look at the same film taken in the form of PA view and AP view. PA view is the one that is, I said, it is a good view, universal view without any magnification of the heart. And here we can see the apical areas, that is the apical areas of the lung distinctly. Whereas in AP view, the heart is magnified and epiphysis that is always seen above the clavicle, that is not seen properly here. Sometime in a child with a 6 year or 7 year, they may either we can take PA view or AP view, but you should know how to differentiate between the AP and PA view. I usually teach if X-ray shows, I look at the very easily, look at the stomach shadow. If the stomach is having air fluid level, that is probably a standing position. That is the way I usually teach. And another important thing is PA view is the one, here the clavicles are horizontal and very nicely placed, whereas in sometime in AP view, the clavicles may be kinked. You should know how to differentiate between AP view and PA view. Coming to the reading, many people teach X-rays in a different ways. From my early days, I teach X-rays in a different way. After all, in X-ray, the three important things that you are going to see is, one is the mediastinum, second is the lung parenchyma, the third one is the bone and soft tissues. I usually insist students to make three imaginary vertical lines. Actually, it is imaginary vertical line. First vertical line, can you see the red one that passes through the mediastinum? Second vertical line that passes through the parenchyma is a blue line. The third one, can you see that here is a third line, this vertical line that passes through the bone and soft tissues. Okay, first vertical line, what all the information it gives? Actually, you have to see the borders of the mediastinum. You should know what are the structures that constitutes the right border and what are the structures that constitutes the left border. Actually, right border from above downwards, it is a superior vena cava, and down it is a right atrium. Whereas left side, four structures from above downwards: aorta, pulmonary artery, left atrium, or sometimes we call left atrial appendage, and left ventricle. Then where is the right ventricle? Right ventricle actually forms the base of the mediastinum. And again, normal X-ray, if X-ray is taken correctly, is without any rotation, the normal X-ray is such that here the mediastinum occupies 1/3 on the right side and 2/3 on the left side. That is a normal X-ray. Sometimes if it is not there, it may be a rotated film, or there may be pathology in the lung that either push or pull the mediastinum. That's the reason why I always insist the X-ray to be taken without any rotation. I'll tell about the rotation, how to take and all, and how to identify the rotation and all in the subsequent X-rays. Then what are the conditions that push the mediastinum? There are four conditions that push the mediastinum. That is obstructive emphysema, that is happening in the lung. Pneumothorax and pleural fluid, that is nothing but a collection of air and fluid in the pleural cavity. And again, there is a space occupying lesion in the lung itself. We push the mediastinum. All the four pictures are given here. First is the obstructive emphysema, and the second is the pneumothorax, and the third one is the pleural fluid on the right side. The fourth one is the congenital, probably pulmonary airway malformation on the left side, that pushing the mediastinum to the right. Here pathology is the right side pushing the mediastinum to the left. Here also the pathology, that is pneumothorax on the right side pushing the mediastinum to the left. And here the pleural fluid on the right side pushing the mediastinum. It's a mild pleural fluid. And again here the pathology, that is a cyst, that is a congenital cystic adenomatoid malformation on the left lung pushing the mediastinum to the right. Sometimes it is difficult to differentiate between the obstructive emphysema and the pneumothorax. Actually, how to differentiate? You look at two important things. One is the bronchovascular markings. Second thing is the collapsed lung. Look at here. You can see the collapsed lung and with hyperlucency and such a picture. And here also there is no bronchovascular markings. So there is a collapsed lung, no bronchovascular markings, and such a picture is going with the pneumothorax. Whereas here there is a slightly hyperlucent, but you can see the bronchovascular markings, but there is no collapsed lung. So it is a pathology that is happening in the lung, that is right side of the lung. What is the condition that causes obstructive emphysema? The most important thing is the foreign body. Okay, this child happened to aspirate foreign body. The foreign body, that is a peanut, is sitting on the right bronchus, acting as a ball wave that causes a obstructive emphysema. You have to know how to diagnose the obstructive emphysema. That is very important because it is emergency and the child need to be subjected for scopy to remove the foreign body. What are the conditions that pull the mediastinum? There are four conditions that pull the mediastinum, namely collapse, hypoplasia, pleural thickening, and the bronchopneumonia. Sometimes, not always. And collapse is always, sometimes otherwise called as atelectasis. Hypoplasia is not only hypoplasia, it may be hypoplasia agenesis complex. It may be hypoplasia, aplasia, and agenesis. All these conditions pull the mediastinum to the same side. Look at the pictures. Here there is a collapse. Where is the collapse? It's a retrocardiac collapse. The collapse is happening in the left lower lobe. So naturally it pulls the mediastinum to the same side. It is the left side. Here hypoplasia. Where is hypoplasia? Right side or left side? So hypoplasia on the right side. So that is the reason why the entire mediastinum, including heart, everything shifted towards the right side. Here there is no lung. That is the reason why mediastinum occupies that. Sometimes after the management of empyema, child may develop pleural thickening. So the pleural thickening is the one that causes pulling of the mediastinum. Here, pleural thickening, this child is managed as empyema. Left side, there is a pleural thickening that causing pulling of the mediastinum to the left. Bronchopneumonia, very rarely it causes because there is a microatelectasis that may either sometimes pull the mediastinum. Coming to the second vertical line, that is a blue line, it crosses through the parenchyma. So, what are the things you have to see in the lung, in the parenchyma? Right. First of all, you should compare the volumes of both sides. Normally, right side is having a bigger volume than the left side because right side there are three lobes, right upper lobe, right middle lobe and lower lobe, whereas here only two lobes. And so naturally you have to compare, and any discrepancy you have to think of why that is happening. Is there any fibrosis or any hypoplasia or collapse? All these things you have to analyze. Again, lungs, if you go into that, if you see the anatomy of lung, that upper lobes always sit on the lower lobes. See, right side, both right upper lobe and right middle lobe sits on the right lower lobe. Sorry, right upper lobe and right middle lobe sits on the right lower lobe. Whereas the left side, left upper lobe sits on the left lower lobe. So it exactly you cannot pinpoint the density or pathology. That's the reason why we divide X-ray into three zones. Either the density belongs to the upper zone, that is a pneumonia or atelectasis belong to the upper lobe or upper zone, or mid zone or lower zone. How to do that? You simply make three horizontal markings. The first one, upper zone, is the one, it extends from the apex to the lower border of the anterior end of the second costal cartilage. Anterior end of the second cartilage. The middle zone is the one, from the above line, it extends to the lower border of the fourth costal cartilage, and it includes the hilum. The lower zone is the one that extends from the above line and go up to, that is a fourth costal cartilage, to the base of the lung. So if you see any pathology here, you have to say the pathology, that is the density or opacity or cyst, it is sitting on the upper zone. If you see here, it is a middle zone. You should not say it is a lobe. So you always, in X-rays, you use the word zone, upper zone, mid zone and lower zone. Can you see there is a big shadow, then density, and what is that? Probably the density is the one right upper zone as well as extending to the right mid zone. What is that? Such a picture is always go with the pneumonia. So you have to call it as a right pneumonia of the right upper zone. Here the densities are seen on right side. There are two pictures. This is what, this is what. Actually, this is a pneumonia, this is a collapse. What is the difference point? Actually, you should know how to differentiate between pneumonia and collapse, though both the condition, both the one produce density. Pneumonia, there is no, it's a normal volume. Actually, there is no reduction of the volume and it may not cause shift. Sometimes we can see the air bronchogram, and it may involve the entire lobe or segment like that and all. Whereas same collapse, if it is happening in the right upper lobe, there is a volume loss. So you can see the triangular shadow. Triangular shadow, it's a well defined one. It extends up to the periphery. And there is a ipsilateral shift of the mediastinum. You can look at the mediastinum here. Normally 1/3 and 2/3. Here the mediastinum shifted to the right side. So collapse is the one triangular. It extends up to the periphery. That is very important. So now I am telling something about the lump, second blue line that passes through the parenchyma, and some more information. And here you can see a density that silhouetted out the right border. Okay, what is the one? Whether it is belong to right middle lobe or right lower lobe, it may be one of the things. What you usually say that one X-ray gives only two-dimensional view. It doesn't give any information about the depth. So by silhouette sign we can find out whether the pathology is happening in the middle lobe or the lower lobe, or look at sometimes the density may happen here, or density may be happen here, or density may be happen here. So if a density silhouettes means obscures a part of the lung, then the exact underlying lobe of the lung can be detected where it silhouettes by looking at that. For example, if it silhouettes here, it's upper lobe, like that and all. Like that. See, the density silhouettes here, it is a light upper lobe. Then it's a here it means a left upper lobe. Anything, if the density silhouettes the left border, it usually belongs to the lingula. Whereas right border, it usually belongs to the right middle lobe. Okay. If the density silhouettes here, the lower dome of the diaphragm, then it is a right lower lobe. So this is very, very important. For example, this density silhouettes, that means obscures the right border. And what is a pathology, where it is happening? So the pathology is that the right border is silhouetted out, so it belongs to right middle lobe. So sometimes instead of the density is there, but still you can have a defined right border is nicely seen, then the pathology is in the right lower lobe. Like that, here the density silhouettes the left border. So I already said that any density silhouettes the left lower border, so that belongs to lingula. Okay, and if it is very nicely seen, then density is there, but you can also see the left border, then it may be the pneumonia may be in the left lower lobe. So silhouette sign is very, very important. And again, expert radiologists, by looking at the X-ray itself, they suggest what is a possible underlying organism, what is a microorganisms also. Look at the density or shadow, that is a round one seen in the left mid zone. Okay, and whenever there is a round density is there, and it is a suggestion of streptopneumonia. Don't come to the conclusion of streptopneumonia and suggest. Actually, same idea, I happen to manage a child with a round one. Actually, the round shadow is there in the left hilum. Actually, later it turned to be a different tuberculosis pathology also. So we need to go. Some X-ray have a lot of limitations. So in that case, you have to go for other higher modalities like CT. That is very, or sex CT. Contrast CT is very, very important. Here you can see the infiltrates on both sides. We can also see the cyst on both sides. The cysts are more on the right side, and such a picture is typically goes with staphylococcal pneumonia. That is multilobar shadowing with the nematocils, right side domination. All these things are, and that too if the child is presenting with a small furuncle and the pneumonia happening after 3 to 4 days later, and such a clinical history is there, you can say that the child is suffering from staphylococcal pneumonia, and accordingly you can choose the antibiotics. Here you can see the apices. Okay, look at the left and right, and the right apices you can see cavity as well as some infiltrates. It is called fibrocaseous lesions. Okay, cavity lesions with the fibrosis, and that typically suggests tuberculosis etiology, that is adult type of TB. So this is the one, if a child is presenting with a cough, fever for more than 4 weeks, and the child also presenting with some loss of weight and loss of appetite, some hemoptysis, and you see X-ray, I think it's almost confirmed adult type TB. But still, we need to have a molecular diagnosis nowadays. Nowadays, upfront, you have to have such a child, the child should be subjected for some CBNAT. Okay, that is a commercially it is called Gene Expert and all. You take either a gastric lavage or induced sputum and subject them for CBNAT, that is Gene Expert, and it not only confirms tuberculosis etiology but also tells about the rifampicin sensitivity. That is very, very important. Nowadays, you should not stop with diagnosing tuberculosis. You have to go whether the child is sensitive to rifampicin by doing CBNAT. That is a molecular diagnosis should be done. That is very important. Again, can you see that there is a density is seen, but in the density one more density is seen, and again lower one hyperlucency. Here to me some node is sitting on the right side, right bronchial system, and compress, and the compression is partial, that is probably in the lower lobe it is causing hyperaeration, but probably in the middle and the upper lobe it causes some pneumonia. And such a picture is typically goes with tuberculosis. You have to know about that. And tuberculosis is notoriously produce segmental lesion. Segmental lesion is all because of node. When the node compresses or erodes the nearby bronchi, initially it may produce a consolidation. Later it can go on collapse. So in the same lobe, you can have two findings. That is collapse consolidation. That is typically goes with the tuberculosis. That is called segmental lesion. Right. Here, what is X-ray? X-ray, it looks like a slightly hyperventilated, and the right border is something like a very uniform bow-like, and here you can the domes are domes are depressed, and you can also see the that is a perihilar infiltrates. Such a child presenting with probably a 6-month-old child presenting with a cough, coryza, and wheeze, and that typically goes with the bronchiolitis. So bow sign is the one that typically goes with the bronchiolitis. Here, what is that? Look at the mediastinum. Mediastinum is shifted to the right side. You can what is the reason? There is a lot of cyst, nematocele. So not nematocele. It is mostly looks like there is no empyema history. So it is a very young child. So there is a cyst or happening in the left side that pushes the mediastinum's right side. So it is nothing. Those days we call as a congenital cystic adenomatoid malformation. Now terminology is CPAM, congenital pulmonary airway malformation. There is a CPAM of the left lung pushing the mediastinum to the right side. Look at the air and fluid filled cavities. You can see that the left side mid zone. So such a picture goes with the abscess. So lung abscesses. Okay, multiple lung abscesses in the left lung. Can you see the bilaterally? You can see miliary mottling like picture. What are the conditions that produce? It is a miliary TB, maybe that. Still more, actually, it's not a very typical one. Sometimes it is maybe millet-like, and over the time it may coalesce to form little bigger size and all. So any nodular lesions, sometimes it may go with hemocyarosis or histiocytosis, or sometimes tuberculosis, miliary tuberculosis and all. Reticular shadows also may be there. Sometimes sticky infiltrates may suggest it is a atypical pneumonia, or maybe interstitial lung disease and all. Alveolar filling shadows may typically goes with pulmonary edema or ARDs and other things and all. So we finish the first vertical line passing through the mediastinum, second vertical line passing through the parenchyma. Now we will talk about the third vertical line that go through the bone and soft tissues. Okay, right. Most of the times, technical qualities like whether the film is taken correctly, is it a rotated film, or it is a good inspirated film, or the penetration is good. All these things we can find out by looking at the bones. Look at the medial end of the clavicles. If the medial end of the clavicles are equidistant from the mid-sternal line or the spinous process, it is a normal film. It is not a. Otherwise, if it is not equidistant, it is a rotated film. So most of the times we advise to take a normal film because it is very difficult to comment about the mediastinal shift onto the rotated film. So you have first to see whether the film is a normal film or rotated film. Then only you can comment on the mediastinal push or pull. Good insulated film is such that if you count the anterior ends of the ribs, look at this is a clavicle, you all know. This is the first rib, this is second rib, this is third rib, this is the fourth rib, fifth, sixth. So 6 ribs. So 6 anterior ends of the ribs are above the right dome of the diaphragm or left. That is a good insulated film. Some people say counting the posterior ends also is possible. I think it's always better to count the anterior ends. Say this is the first rib, second rib, third rib, fourth rib, fifth rib. Actually, if you count the posterior end, it goes like this. First posterior end, 1, 2, 1, 2, then it will 3. So it is very difficult. So you better go with the anterior ends. Actually, this is a X-ray of the same child. One is taken in the good film, that is the inspirated film. The other one is the probably expiratory film. See, inspirated film gives a lot of information without any, you cannot miss it. In expiratory film, we can wrongly diagnose it, maybe a cardiomegaly or other things and all. That is the reason why you have to take a good inspirated film. Now, we'll move on to the penetration. What is a ideal penetration? What is a poor penetration? Okay. To differentiate that, we have to always look at the upper thoracic vertebra. That is anything between the T1 to T4. Actually, when the clavicle joins, it is a second thoracic vertebra. So 3, 4 or 5, these upper thoracic vertebra are just visible through the mediastinum. If it is there, it is a good film. You are not able to see the upper thoracic vertebra, then it is a poor penetration. That way you can see this is a good ideal penetrated film. Here is a poor penetrated. You cannot see anything behind the mediastinum. And this is also given the same thing. See the medial end of the clavicle, T2, T3, T4, T5. These are the things. So now some more points about the third vertical line. We already talked about the bone and bone issues on the third vertical line. Look at the soft tissue also. Sometimes if you look at the soft tissues, you can see the air column in the neck. Okay, and such a picture is typically goes with the Ehrlich syndrome. What are the conditions that produce Ehrlich syndrome? One, it may be acute asthma, or it may be due to the foreign body. Sometimes it may shift the mediastinum, that is called pneumomediastinum, or it may collect under the peritoneum, pneumoperitoneum, or it may go into the soft tissues. So such a things you should be in a position to diagnose. The limitation of the X-ray is it differentiates only 4 densities, namely air density, fluid density, and soft tissue calcification. Wherever they come close, the interface will be seen very distinctly. Otherwise, for example, 2 or 3 soft tissues, what is happening in the mediastinum? All are soft tissues, so you cannot able to differentiate on the neck shadows and all, or the upper mediastinum and all. There you have to go for as either a CT, contrast CT, or MRI and all. This is the last X-ray. The child they brought with only one X-ray, and the child is typically sick looking. For me, it looks like a miliary. So, but when I keenly see that there are some cysts also happening, so immediately ask them to go for CT. CT gives a nice picture. Okay, you can see the cyst. The cysts are bilateral varying size, and that typically goes with what? LCH. Okay, LCH is a one condition that produce multiple irregular cysts, and there is no differential diagnosis. If at all, one thing that is called lymphangiomyomatosis that is happening in a older age, particularly female and all, or sometimes that lymphocytic interstitial pneumonia. All these things are not fitting with the child. So we made a diagnosis of Langerhans cell. Actually, the child was subjected for biopsy, cryobiopsy, and it is confirmed. So I told many things about the X-ray. Probably, thank you. We'll meet in some other occasion on some other topic.